I just get an idea? How many of you actually see patients or are nurses, nurse practitioners, physicians? Okay, great. I was wondering that yesterday, so that's wonderful. So I'm Dr. Gilcrease. I'm from the University of Utah. It's really a pleasure and an honor to be here. I'd first like to thank Dr. Vinay Shah and the foundation for organizing such a wonderful event, and really it's an honor to be here. My role today is moderator. If you notice, we're all Dr. G's, and so in the clinic, Dr. Greedo and I often get mixed up, and you had to have a G to be part of the GI team. So it's a pleasure to introduce Dr. Axel Grothey. He was from the Mayo Clinic. He's really a leader and a pioneer in colorectal cancer, and I'm super excited to hear from him today. So Dr. Grothey.
Thank you very much, and thanks, Vinny, for having me again. You might have seen here I moved on from Mayo Clinic to some warmer temperatures. You know, they reassured me that in Tennessee you would not have ice and snow. Ice, yes, but not necessarily as much snow as we had in Rochester. So that's one of the incentives of being in Tennessee now. I'd like to update you on colorectal cancer and embed the ASCO and actually Barcelona World GI updates into kind of a more overview talk about colorectal cancer to place it into context. So, and very quickly, I know we've talked about this last year and I talk about this all the time, but I just want to reiterate the idea that we have a lot of treatment options, medical oncologists, in the management of metastatic colorectal cancer. And recently we included PD-1 antibodies, pembrolizumab, nivolumab, with or without ipilimumab. The challenge is really how do we treat patients individually? And we look at a lot of different patient factors, you know, like patient characteristics, molecular characteristics of the cancer, tumor-sidedness, and I will devote a little bit of my talk to tumor-sidedness discussion, patient preference. And we use this intuitively in order to really identify the best patient for individual patients sitting in front of me, because most patients actually in a palliative situation when they come with metastatic disease, some patients can be cured, but most patients are in a palliative setting, and our goal is to keep them alive in good quality of life. Again, we can cure some patients, but the majority of patients is really in this marathon of sequential therapies and not a sprint. And it's something that I like to communicate to my patients, because it is a very important point when you consider patients will be alive for several years, and we use the treatment options we have in a strategic manner. And patients need to understand that they might never come completely off medical therapy. We'll give them breaks in between. We really try to maintain their quality of life. But eventually they benefit from access to all active agents. That is what keeps them alive. Another important point that has come out recently or more in recent years is we have biomarkers who identify patients who do not respond to certain therapies like RAS mutations for EGF-receptor antibodies. And more recently, however, we have biomarkers identifying patients for a specific intervention. And I'll come back to that and I'll give you some updates on that too, like HER2 and BRAF and MSI high. So again, to set the stage, outcome is not driven necessarily by first-line treatment for the majority of patients. And if anyone tells you that first-line treatment is the most important treatment ever, it's only partially true. First of all, it's true because this is the time that patients are on treatment the longest, because progression-free survival is longer in first than in second line. And of course, whatever you do in first line determines what happens in second line, because you switch treatments. But when you look at overall, and this is important, the progression-free survival improvements, they really didn't happen in first-line therapy over a decade. Even with the advent of biologic agents, bevacizumab, cetuximab, data selection, etc., we're still stuck below 12 months in first-line progression-free survival. But overall survival has increased over time, and this is related to all the things we're doing, sequential therapies, you know, second, third, fourth-line treatments, surgical interventions, embolizations, etc. It's a whole bag of different approaches that we as oncologists should utilize. Now, coming more to the updates and what's happening right now in colorectal cancer, the key question in first-line treatment is still, which biologic agent should you use? I mean, way back when, about 15 years ago, the question was, should we use oxaliplatin or irinotecan? and this was kind of a religious war about these two different chemotherapy drugs. And as soon as these drugs became generic, no one cared anymore, and it was a wash. And similar things is happening right now. Who should receive which therapy? And I think we have a better idea now. I believe I can identify patients much better now who should be candidates for EGF receptor antibodies, which in first-line therapy in the United States are, I think, underappreciated. We'll come back to that. Very quick points on anti-VEGF therapy, because there's one point that is very dear to me. Duration of VEGF inhibition matters. We're talking about a cytostatic drug. Bevacizumab, like aflibercept, ramucirumab, they are cytostatic drugs. They don't shine by reducing tumor volume. They make chemotherapy work better in the sense that tumors don't progress as fast. And if you have a cytostatic drug, as soon as you take it away, tumors start to grow. So duration of therapy matters for anti-VEGF therapy more than for any other treatment. And we have clear data, treatment to progression, maintenance strategies, using the synergism between fluoropyrimidines and bevacizumab, like capecitabine, bev. And you even have 3 phase 3 trials for prolonged VEGF inhibition beyond progression. That's something very interesting, that even when tumors progress on first-line treatment, you continue VEGF inhibition and you have a survival benefit. Moderate, but you have a survival benefit. Now, the more interesting part for recent developments is that we have refined the patient population that benefits from EGF receptor antibodies. And EGF receptor antibodies, as you know, don't have good press because they're stigmatizing patients, with a rash. They might have diarrhea. They're expensive, and they're really not the drugs that patients want to have unless it works very well and prolongs survival for them and really changes tumor biology. And I do believe we identify these patients now better who should be candidates for EGF receptor antibodies. And part of that is our analysis of sidedness. We now know very specifically that right and left-sided colon cancers behave very differently biologically, in their prognostic implication for treatment, but also in terms of response to anti-EGF receptor therapy, which I think is very critical. And I'll show you some of the data. So left and right-sided colon is different based on molecular pathways, based on embryogenesis, hindgut versus midgut derived, and we'll come back to that in a second, the microbiome, which is very different between right and left-sided tumors. And I strongly believe that a lot of the mysteries that we see right now in responsiveness to therapy and prognosis are related to the microbiome. So what about prognostic implications? Peter O'Dwyer study, ECOG study, 1,100 patients at a time when we just played with 5 of you, showed a difference in median survival of 5 months between right and left-sided tumors. Clearly a prognostic implication. Right-sided tumors have poor prognosis. Now we add a last-line colon cancer study to it, cetuximab versus best supportive care. You see the benefit in right-sided tumors here is non-existent. It only happens in left-sided tumors. And that is really a predictive implication, at least the idea of predictive implication, that this is something that happens only in context of the EGF receptor antibodies. And we have data, a lot of data, very consistent data. For instance, from the CRYSTAL study, first-line FOLFIRI plus minus cetuximab, left-sided tumors, you see there is a difference in PFS and OS. Right-sided tumors, absolutely no difference. Right-sided tumors, RAS wild-type, BRAF wild-type, do not benefit from cetuximab or panitumumab. Here's the panitumumab data, PFS, panitumumab plus FOLFOX or FOLFOX alone. Left-sided tumors, you see the difference. Right-sided tumors, the dotted lines, no difference. So sidedness is an additional predictive factor on top of the RAS mutation analysis. I think the best data, though, we have come from the US trial, the SWOG CLGB8405 study. This is very important when this is probably the most important slide you see today. You see this is cetuximab treated patient plus chemotherapy, left-sided tumors, median survival 39.3 months, right-sided tumors 13.6 months. There's a difference for more than 25 months between right and left-sided tumors when you use cetuximab. Now the bevacizumab data here, because this trial compared bevacizumab to cetuximab, you see there's a little bit of a split between left and right-sided tumors, but clearly not as wide as cetuximab. And I can tell you the NCCN guidelines looked at this data here, this data set, and and said, we are concerned that right-sided tumors would actually have a detrimental effect from cetuximab. And the Europeans said, left-sided tumors derive a benefit from cetuximab. And this is actually the reason why we see the difference in NCCN and European guidelines recommendations. And I'll come back to that in a second. For me personally, the perfect candidate for first-line EGFR antibody therapy is, of course, negative selection, RAS mutation, negative selection, BRAF mutation. I'll show you some data on that in a minute. HER2 amplifications emerging. So we're eliminating about 65% of patients right up front by molecular testing. And then overlapping, which is not mutually exclusive, are right-sided cancers. So what remains are about 20 to 25% of patients with left-sided RAS-RAF wild-type tumors that should receive EGFR antibodies. It's the similar percentage as HER2 positive patients in breast cancer. Those patients should receive cetuximab. And this is really more or less what's reflected in the guidelines, the ESMO guidelines, the NCCN guidelines. Left-sided tumors per ESMO guidelines, RAS-RAF wild-type EGFR antibodies are standard of care. The NCCN guidelines do not commit to one way or the other. They don't even put a preferred in there. In right-sided tumors, EGFR antibodies can be considered if first-line, if response is a goal. And NCCN guidelines say no, don't use them in first-line. My personal preference, and I would never consider myself on the same level as NCCN and ESMO. I should probably move myself down here. I think EGFR antibodies are preferred in left-sided RAS-RAF wild-type tumors. Use it more. I think the Europeans should use it less, but we should use it more. Bevacizumab can be used in select patients. I would not use EGFR antibodies in first line.